Good afternoon, and it's good to see a few more people managed to sit down rather than stand up. There's a bit more oxygen in the room and a bit less CO2 perhaps. I'm Julia Wendon. I love livers, they are my passion. When everyone else thinks they're yellow and nasty and bleedy, I think they're great fun. But today I'm going to talk about the cardiorespiratory complications of cirrhosis predominantly, and focus mainly on hepatopulmonary and portopulmonary syndrome. But very much, if I say something that you don't agree with, just put up your hand or shout, and I'll stop, and we'll discuss it. But otherwise, it gets a bit sort of samey lectury. We'll see how it goes. First thing, that's me. If you want my slides, I think they'll get uploaded anyway, but please feel free to email, and I'm very happy to have email discussions about anything. So the areas that I want to talk about really are portopulmonary syndrome, which we'll talk about a bit more, but basically means you get pulmonary hypertension in association with elevated portal pressure. You do not need to have cirrhosis, and that gets really important when you decide what to do with these patients. Hepatopulmonary syndrome is when you shunt through your lungs and you get hypoxic, and it is seen in cirrhosis. It's fascinatingly also seen in right heart severe dysfunction, which previous speaker might allude to as well, where you start getting dilation and hypoxia. And that's a fascinating bit of congenital heart disease. We'll talk briefly about cirrhotic cardiomyopathy, liver congestion, and hypoxic hepatitis. Less about ischemic heart disease, valvular heart disease, and the like. If it's severe, in the context of cirrhosis, you can transplant and do your cardiac surgery at the same sitting. If one is less severe than the other, you might progress with one with an option for the other, but you can get into a bit of a mess doing a transplant in someone with bad cardiovascular disease. Just to remind you all that when your heart doesn't work, your liver's unhappy. The right atrium is intimately connected to almost your hepatic veins, and as soon as your hepatic venous pressure starts going up, related to an elevation in your right atrial pressure, you will see congestion coming down those hepatic veins. That pushes on your biliary epithelium, and that's why you see a high alkaline phosphatase in people with right heart failure. So high alk phos, high gamma GTP, yes, it can be drug-induced from drugs people are on. It can be alcohol. It can also be right heart dysfunction. So always consider that. Similarly then, as you get left-sided dysfunction, you see the transaminitis. And abnormal liver function tests associated with heart failure are a poor prognostic sign. That hypoxic hepatitis that we all see in our everyday life, marked transaminitis associated with coagulopathy. I only think it's interesting if you've got significant hepatitis, i.e. an AST of over 1,000, though the definition is somewhat lower. Equally, you need coagulopathy. The common causes are an existing right heart dysfunction with a congested liver, and then an episode of hypoxemia because of acute respiratory distress, or hypotension with impaired forward flow, which might be atrial fibrillation, it might be volume depletion. And in those two contexts then, you get a significant hypoxic hepatitis. You can also see it in a cirrhotic who has a variceal bleed or septic shock, drops their blood pressure, who has portal vein thrombosis, because they are totally dependent on arterial inflow to perfuse their liver. So that's another context where you might see hypoxic hepatitis. Nice CT where you see the congested hepatic veins related to right-sided dysfunction. The prognostic features are associated with cardiogenic shock, septic shock, carrying a significant ICU mortality, and as you see there, the coagulopathy greater than an INR of 2 or a SOFA score of greater than 10. But the bottom line is support the heart and the lungs, and the liver will get better. It is a very forgiving organ. And you can just sort of leave it in the background in hypoxic hepatitis and focus on the heart and the lungs and getting them better. I would say I have had the misfortune once of being presented with someone with a diagnosis of acute liver failure with a very high INR and a jugular venous saturation and a right atrial saturation of 25%, who was actually an acute cardiomyopathy. So the two can link together. And clearly, once you have a hypoxic hepatitis, your ITU mortality starts rising. I think the other thing, and COVID perhaps brought it home to us, that you do need to think about in patients with a severe ARDS, severe hypoxemia, is the risk to your biliary tree. Your biliary tree is perfused almost entirely by your hepatic artery. So hypotension and associated hypoxia, which is long-standing, of significant duration in ITU, and you can start seeing biliary ischemia. And this study here demonstrates that if you follow these patients up, some of them actually start getting ischemic stricturing of their biliary tree, and they look to all the world like secondary sclerosing cholangitis, and a small cohort of them can go on to need transplantation. Another good reason to follow up our ITU patients and think somewhat laterally if they have cholestatic liver blood tests. So on to the meat of the talk now, which is really thinking about respiratory failure and hepatopulmonary syndrome. My glasses don't do this. It's quite interesting. I can't see that at all, and I can't see this because of the angle. So I'm doing a lot of this from memory, so my apologies. But basically, your cirrhotic is at risk of aspiration because they become encephalopathic, and we all leave them on the wards, and we give them a bit of haloperidol, and we try and keep them there as long as possible before we intubate them. And what happens is you're getting more and more drowsy as an encephalopathic, you microaspirate. And lo and behold, you get chest sepsis. So early intubation in this cohort is really worthwhile. There is a significant overlap with interstitial lung disease, primary biliary cirrhosis. Many of the immune-mediated liver diseases also have an interstitial lung disease that one should consider. But the hydrothoraces, as you see here, can be particularly troubling. They are ascites draining into your pleural space. They are usually right-sided, but they can be bilateral. They are usually associated with ascites, but not always. Now, one of the things to remember is they can get, like bacterial peritonitis in your ascites, you can get the same in this fluid here. So always tap it just with a green needle, see whether it's infected. If you need to drain it, you can nearly always drain it through an acidic drain rather than a pleural drain because of all the fenestration in your diaphragm. As you drain your ascites, your pleural fluid drains as well. But in those without significant ascites, you do sometimes have to put an intercostal drain in. Do recall that there are intercostal varices, and it is deeply unpleasant when you put something through one, and they bleed like stink. So I must admit, they are something I view with great caution and consider a high-risk procedure for bleeding. And without question, the Seldinger technique is slightly more dangerous in that regard than the old-fashioned put your finger through, because it's a sharper tip that you're pushing through. How can you manage them? It's difficult, and this is a cohort that do respond to TIPS shunting sometimes, so TIPS can be used for chronic hydrothoraces. And likewise, sometimes, just like ascites is an indication for transplant, so can this be. So always consider that. The hepatopulmonary syndrome is wonderfully livery. You have fantastically cyanosed patients with lovely clubbing, and you sit them up and they desaturate, and you lie them down or even put them head down and they pink up a bit, and it's lovely. It's a fantastic diagnostic trick. Medical students adore it. I like it. Diagnosis, bubble echocardiography. Most of us now will use bubble echo rather than microaggregated albumin, but you can use either. Importantly now, because many of these patients have relatively preserved liver function, it's often not that bad, is that you can list them for transplant with a MELD additional score. So one does need to think about that. The pathophysiology is really still not understood. There are lots of angiogenesis factors that are being considered, and at the moment the endothelial glycocalyx is very much in fashion, as it breaks down and you get inflammation and you get release of damps in cirrhosis. This is thought to be part of that inflammatory milieu that perhaps drives these small arteriovenous malformations within your lung parenchyma that make you so hypoxic. In terms of differential, they've got a significant oxygen defect. The diagnosis requires the PaO2 to be less than 80 millimeters of mercury. They usually pink up beautifully with high flow oxygen. If they don't, think of another diagnosis. And of course, the shunt has to be not an intracardiac shunt, i.e. immediate shift of right to left, but after about 4 beats. You always have a positive bubble echo, and you must have portal hypertension. But as I say, you don't always need cirrhosis. On CT, you can quite often see these very dilated vessels, and some of these can be embolized and ballooned in terms of improving oxygenation. But this is a cohort of patients that will end up on domiciliary oxygen whilst you await transplantation for them. Transplantation can be interesting, and they can get really hypoxic post-transplant. You need to think occasionally about ECMO, and it's a difficult decision to make. We usually do it on the basis of significant hypoxia plus concern that the liver is suffering, the AST is going up, the alk-phospho-gamma GTP are going up. That might push you towards ECMO. But if you're doing the severe end of the spectrum, you need to think about having that in your back pocket. Similarly, this study, it's still in press, for which I apologise, the draft across it. But this shows really elegantly that this is a hyperdynamic disease. So the higher your cardiac index, the greater the degree of shunting. One would think, therefore, that maybe you can modulate this with drugs to decrease the cardiac index. But certainly in the trials thus far, that hasn't been shown to be useful. And although people will try terlipressin and other things, it actually doesn't seem to be useful at the bedside. It doesn't stop us trying. So in terms of this, we need to look at medical therapies. At the moment, non-proven. It is supportive in terms of oxygen. Think about liver transplantation. Be sure that we get the MELD additional scores, and in post-transplant hypoxia, as again, we all try terlipressin, we try beta blockers to decrease the cardiac index, decrease that shunt, but you do on occasions end up on ECMO. And it's a long haul. So similarly, we now move to almost the contrary of this, which is portopulmonary hypertension, which is again, portal pressures are elevated and you have elevated PA pressures. It's seen in about 10 to 20% of cases, and it can be seen in association with hepatopulmonary syndrome. They are not mutually exclusive, and some patients move across from shunting to having pulmonary hypertension. The treatments, as you see there now, mesatinib through the Portico study, sildenafil, bisantin, NO, and nebulized prostacyclin. What's important is in terms of pathogenesis, it is very like pulmonary hypertension of other etiologies. You do get the hypertrophy, and you can end up in the beginning of the disease, reversible disease, i.e. you intervene and the PA pressures fall. As the disease progresses, it becomes static and fixed, and at that point transplantation gets very dangerous and probably not something to go down. Pulmonary hypertension in association with cirrhosis has now really been split into these categories. So you have a degree of pulmonary hypertension just by virtue of your profound hyperdynamic state. And these patients are hyperdynamic. Most of them will have baseline cardiac indices of about 4 liters. A proportion of them are volume overloaded. And you have to be really cautious that a lot of our hepatology colleagues use gallons of albumin, as much as they can get into these patients. And what a surprise, they get right-sided volume overload. And at that point, you can see this pulmonary hypertension, pulmonary venous hypertension, and you normally see an elevated cardiac index still, and the wedge pressure is sometimes increased. You can then see the pulmonary hypertension, which is arterial in nature. The nature of the game is to try and diagnose this when it's still reversible, and you can use therapeutic interventions whilst you consider transplantation. And the untreated, where you've got falling cardiac index, is very bad. So in terms of the risk factors, you can see that females particularly, those with autoimmune hepatitis, whilst those with hepatitis C appear to be protected. The reasons for that are unclear, but interestingly, in terms of the females, some more recent data coming out 2 years ago now, looking at estrogen signaling, and again showing that there are actually pathways now that we might be able to intervene with in terms of modulation of this disease. And this is where it becomes interesting as well clinically. So this is a lady who presents with hematemesis, previous alcohol consumption, typical Friday night. She's got lots of ascites, and she's very jaundiced and is encephalopathic. She's got profound bleeding. She's intubated and a Sengstaken tubes inserted. She has her varices banded, but you need to do the echo. And as you can see from that echo, she has significant portal hypertension and pulmonary hypertension with elevated right-sided pressures. If you tip someone like this, all you do is equilibrate your pressures between your portal vein and your right atrium. Portal venous pressures in these sorts of patients are usually about 24 to 30. Your right atrial pressure is probably about 24 in this context. You can actually not improve things at all. And if you do a TIPS and it's not working, someone's still bleeding, always think, have I got right-sided pressure overload? And is that contributing to the condition which I'm now finding myself in? She underwent pharmacological therapy and then eventually was TIPSed with good response and subsequently transplanted. Now, deciding how to manage these patients, whether with medical intervention, pharmacology, or transplantation, is interesting. And most of our transplant surgical colleagues will say transplant, transplant. But this data, which is really good, albeit quite old now, shows very clearly that if you don't have portal cirrhosis, or if you're just mildly cirrhotic, Child-Pugh A, you actually do quite well with medical treatment alone. The ones that you should be transplanting are the cirrhotic Child-Pugh Bs and Cs who have got pulmonary hypertension. The others, as you see here, and the As, manage them medically, at least in the first instance. And that's really based on the data which I'll show you shortly in terms of graft failure following transplantation. This is a high-risk group. So we've got here again summarizing in terms of the portal hypertension, pulmonary hypertension disease, the presence of portal hypertension, a mean pulmonary airway pressure of greater than 25, a wedge of less than 15, and a pulmonary vascular resistance of greater than 240, and then you can categorize it as to mild, moderate, or severe. This is a really nice study. Unfortunately, Child-Pugh Cs and males greater than 19 were excluded. They went to transplant probably too fast as well. But methastatin was truly effective in decreasing pulmonary vascular resistance and modulating the physiology of this patient cohort. And this is why you want to do that before you think about transplanting them. Because Those with a higher pulmonary vascular resistance, as you see here, have a significantly higher morbidity, graft failure rate, and mortality. So intervening, controlling that pulmonary vascular resistance is really important in the management of these patients. So just briefly now moving on to cirrhotic cardiomyopathy. It's a common disease. It's diastolic dysfunction associated with cirrhosis. It's much more common than it is given credit for. And by and large, we all looked at it and just said, look, the QT interval is prolonged. You've just got to be careful when you're using various drugs that might prolong the QT interval. But increasingly now, we are recognizing that it is a morbidity factor in its own right. And if you look at this data, looking at survival for patients with LV diastolic dysfunction following transplant, you see that there is a difference. So this is a factor that in fact impacts on your outcome, and we need to look at it more often. What's also interesting in terms of this data is one at the top, you can see that they have changed the echocardiographic definitions of cirrhotic cardiomyopathy to include systolic as well as diastolic dysfunction. But also importantly, it is a risk factor, quite for getting transplantation, for going on to get heart failure and also coronary vascular disease. So there is something about a heart which is responding to a cirrhotic state, which is fascinating in terms of the long-term management of this patient cohort. And so, what would I like to say in conclusion? That cardiorespiratory disease is common, that the commonest is probably, in order, aspiration pneumonia, avoidable by good airway management. Hydrothoraces, which get infected. And if you're going to drain that fluid, remember that that's going to deplete your central blood volume and change your portal pressures as well. Then you've got the hepatopulmonary syndrome, much more common than we give it credit for. Always think about it in a hypoxic cirrhotic and get your bubble echocardiogram done. And then portopulmonary syndrome, which you need to separate into pulmonary venous hypertension, largely volume overload, can be sorted out with vasodilators and appropriate volume manipulation, and true arterial pulmonary hypertension, where pharmacological therapy and transplantation should be your considered therapies of choice. And I'm going to stop at that point with 2 minutes to go and take any questions that you would like to throw at me.